Hey Echoholics, Jimmy here. Ever wake up in the morning and just can't get going without looking at an echo? Well, we've got you covered, because here is another eye-opener. For those of us who just need a little something extra to get going in the morning, this case came to me a little while back, and it was kind of a trauma one here in 30 seconds kind of deal, where an 88-year-old female, she was witnessed to have a ground level fall and some trauma to her face. Initially, when EMS had arrived, she had been GCS 15 and refusing transport, but over the course of just a few minutes, she acutely decompensated and was reported to have a GCS of 6, and they were going to be on our doorstep any second. So we activate the trauma system. She gets there. Indeed, she has a very low GCS. Her vitals were as follows. Heart rate was in the 130s. She was a little on the hypertensive side. She was breathing on her own, though not making any sounds, not opening her eyes. Was satting fine. However, was on a 100% non-rebreather. So at this point in my thought process, an old lady who fell down and suddenly has a very decreased mental status in my differential is certainly head bleed, and we might consider something like a head bleed, or even she might have fallen and gotten a head bleed. So our priority was to get her to the CT scanner. So she was intubated, of course, and her airway protected, and taken to the CT scanner quite quickly. And we found a brain that looks like this. So no blood was found inside the brain. There are some large ventricles, and so the neurosurgery resident was suspicious of possible normal pressure hydrocephalus, but of course that wasn't explaining her acutely decreased mental status in front of us, but could have explained why she fell, I suppose. So without the obvious answer to our leading differential, we take her back to the trauma bay and continue to take care of the patient. At this point, the trauma service is very uninterested. All she has are some facial lacerations, and they are hoping to get anyone else in the hospital willing to take care of this elderly lady besides the trauma service. Trying to talk neurosurge and neurology and the MICU into taking her, not really understanding yet what is going on with the patient. But we continue to take care of her and get an EKG. It doesn't look normal. Certainly there are some elevations in AVR that seem quite concerning, as well as diffuse depressions. In my book, this is kind of a global ischemic pattern, sometimes seen in proximal LAD or left main occlusion, but also in just diffuse hypoxia. So it makes me wonder what's going on with the heart. And so we, of course, apply some echo in this somewhat apical 4-chamber view that's imperfect, but gives us an idea that the right ventricle here looks significantly larger than the left ventricle, and the right ventricular free wall doesn't appear to be squeezing. However, the apex seems to be spared. That would be the definition of the McConnell sign, which of course is not completely specific for pulmonary embolism, but raises that question in our minds, of course. Applied a little color Doppler, and sure enough, there is some tricuspid regurgitation. So placing our continuous wave through that regurg jet, we get this nice envelope that shows us a pressure gradient of about 45 millimeters of mercury. So during systole, the pressure difference between the right ventricle and the right atrium is 45 millimeters of mercury, which means that the right ventricular systolic pressure, or also the pulmonary artery systolic pressure, is of course at least that. But adding in whatever we think the right atrial pressure is probably more like 55 or 60 millimeters of mercury. So definitely some pulmonary hypertension going on, but we don't know anything about this lady's prior history other than the EMS reported history of Parkinson's. So we don't know if she has pre-existing pulmonary hypertension of any sort, if this is old or new. Applying M mode through that tricuspid annulus, we see that the tricuspid annulus moves back and forth about 1.3 to 1.4 centimeters, which would be a mild to moderately decreased TAPSE, meaning the RV systolic function is a little bit reduced. But again, we can't say for sure whether this is old or new at this point. Now, what would be nice is a pulmonary artery acceleration time, so we could apply the 60-60 rule and be a lot more confident that this is an acute thing if the pulmonary artery acceleration time were less than 60, combined with that pressure gradient that is also less than 60. However, this lady did not have an adequate window to get a good pulmonary artery acceleration time, so we had to do without that. But here is her subcostal view, again demonstrating that the RV is significantly enlarged and that RV free wall does not appear to be squeezing at all. Looking at the IVC, it is of course quite dilated, not collapsing with respiration. However, at this point she is on positive pressure ventilation, so we can't say a whole lot about what we would estimate her right atrial pressure to be. But again, we know that she at least has some element of pulmonary hypertension. So what do we do at this point? Well, we start thinking, well, with that EKG and with that echo, it certainly makes us concerned that she might have syncopized due to a pulmonary embolism, and that caused her fall, which caused her facial lacerations. But again, we don't have a good explanation for why her mental status is so decreased, other than perhaps she's just concussed. So she goes over the CT scanner, and indeed, as we get to that pulmonary artery, there is a large clot burden, saddle embolus, right in the pulmonary artery. And that explains our echo findings for sure, as well as why the patient might have syncopized and fallen. But we don't have a good explanation at this point for why her mental status is so poor. So what happened with this patient? Well, she of course was anticoagulated for that pulmonary embolism. She was admitted to the medical intensive care unit, where they did not administer any thrombolytics, at least at our institution, unless a patient gets significantly hypotensive, which she did not. They do not generally receive thrombolytics for pulmonary emboli. The next day, the patient was extubated and surprisingly enough was neuro intact. So my best guess is that she was just significantly concussed after her acute fall, but perhaps there was a period of hypoperfusion right after she experienced the embolus. It's hard to know, but at least in our care, her blood pressures were always adequate. So what did I take away from this case? Well, certainly trauma is not always trauma, especially when elements of the case are not lining up as we would expect. It's important to realize our anchoring bias, be able to step back and consider a broader differential. And of course, when in doubt, utilize echo. Certainly a properly applied echo can significantly improve your patient's care. And one paper that I have run across recently that illustrates this concept nicely is out of Critical Care Medicine in 2015, where they surveyed the provider both before and after a point of care ultrasound was performed in hypotensive patients. And their findings were pretty impressive, but also pretty in line with my experience in that about a quarter of the patients had significant management change, whether that was IV fluids or vasopressors, blood products, as well as 31% had a change in their choice of imaging, which one would presume that these are all good choices, adding more information to the patient's care that's going to eventually improve more patient-centered outcomes down the line, such as morbidity and mortality. Just a nice article that I think illustrates the benefit of echo in this case, where I have no idea when we would have gotten to the diagnosis of pulmonary embolism in this patient's course. It could have been quite some time. So that's it, Echoholics. There is your eye opener for the day. Hope you enjoyed it, and we'll see you next time.